For the next presentation, still on the topics of prenatal PrEP, the Association of Prenatal PrEP Exposure with Neurodevelopmental and Growth Outcomes among Kenyan Children, from Roland Gomez.
So on behalf of the entire study team, it's my pleasure to present results from a preliminary analysis assessing the association of PrEP exposure with growth and neurodevelopmental outcomes beyond 24 months among Kenyan children in the PRIMA extension study. I have no conflicts of interest to disclose. The WHO recommends offering PrEP during pregnancy as part of antenatal care in high HIV prevalent settings. And several HIV high-burden countries are considering or have already begun launching programmatic PrEP delivery for pregnant women. As PrEP delivery continues to scale up in this population, guidelines strongly advocate for continued surveillance and the need for additional data on longer-term infant outcomes following maternal PrEP use. Safety data of prenatal PrEP use to date are reassuring, though few studies to date include infant outcomes following prenatal PrEP exposure. 3 of the 5 analyses existing to date include data from initial PrEP efficacy randomized clinical trials, where pregnant women were excluded and PrEP was discontinued at pregnancy detection. And therefore, these studies only provide data on early first trimester exposure, which may not be representative of pregnant women at large in these settings. Additionally, studies to date currently only follow up infants till about 1 year of age, and none have assessed neurodevelopment in these groups. Evaluating outcomes beyond infancy following maternal PrEP use could help complete the safety profile for PrEP use during pregnancy. To respond to the call for longer-term safety data following PrEP use during pregnancy, we evaluated growth and social-emotional development among children with and without prenatal PrEP exposure beyond 24 months. We utilized data from the maternal-child pairs and enrolled in an ongoing evaluation of perinatal PrEP use in Western Kenya. In the parent study, a cluster RCT known as the PrEP Implementation for Mothers in Antenatal Care, or PRIMA, HIV-negative women were enrolled and offered PrEP during pregnancy at any gestational age at 20 public sector mother and child health clinics and followed through 9 months postpartum, regardless of PrEP status. PrEP exposure was defined as PrEP prescription during ANC and self-reported PrEP pill taking at any subsequent ANC visit. An ongoing extension cohort to evaluate safety outcomes now enrolls mother-child pairs at 4 PRIMA sites and to be followed till the child's 5th birthday or 60 months. Between October 2020 and June 2022, trained study nurses conducted anthropometric growth measurements of children enrolled in the extension cohort. Weight for age and height for age Z-scores were calculated, and underweight and stunting were defined as Z-scores of less than -2. Using data from between 24 and 36 months for this current analysis, we evaluated the association of prenatal PrEP exposure with growth and ASQ scores using multivariable linear regression clustered by facility. The Ages and Stages Social Emotional Questionnaire is an early developmental screener that identifies children who may be at risk for social emotional difficulties. It's completed at 6-month intervals, takes about 10 to 15 minutes to complete, and assesses self-regulation, compliance, social communication, adaptive functioning, autonomy, affect, and interaction. Scores are calculated against cutoffs that indicate the need for further assessment. Overall, 4,447 women were enrolled in the parent PRIMA study during pregnancy across 20 sites. At the time of the analysis, 775 prior PRIMA participants in 4 sites were enrolled into the extension study, of which 664 meet inclusion criteria for the current analysis and are included. And to note, exclusion criteria for the analysis were women who initiated PrEP postpartum, HIV seroconverted, or had multiple births. Among the 664 mother-child pairs that enrolled into the study, median maternal age was 28 years and median child age was 26 months. Most were currently married, and there were no differences seen between marital status, maternal education, number of living children, and preterm birth among those with and without PrEP exposure. Although those with PrEP exposure expectedly had partners known, more often had partners known to be living with HIV. Women who initiated PrEP during pregnancy did so at a median of 27 weeks gestation and continued on PrEP during pregnancy for a median of 2.4 months. These 119 women who initiated PrEP during pregnancy, about 54% of them went on and continued PrEP at up to nine months postpartum. Looking at growth outcomes, at 24 months, we did not detect any difference in weight or length between PrEP-exposed and unexposed infants. And similarly, at 30 months, we also did not detect any difference in absolute weight or length between PrEP-exposed and unexposed infants. 36 months yielded similar results. You can see that length is about identical at each of the time points, and weight has a very small variability between the two groups. When we look at adverse growth outcomes of growth faltering, frequency of underweight and stunting also did not differ between prenatal PrEP exposure. You'll see in this graph, PrEP exposed are denoted in blue, and PrEP unexposed are shown in the orange graphs. Results were similar at 24, 30, and 36 months for children with and without prenatal PrEP exposure. Moving on to developmental outcomes, we did not detect any difference in raw ages and stages score at any time between children with and without prenatal PrEP exposure. And similarly, after dichotomizing ages and stages score by cutoffs indicating referral for further assessment is needed, which at 36 months was scores greater than 85, and at 36 months was scores greater than 105. We also did not detect any significant differences between those prenatally exposed to PrEP and those who were not. In summary, among Kenyan mother-child pairs followed from pregnancy through early childhood, no differences in growth or social-emotional development in social-emotional developmental outcomes between children with and without prenatal PrEP exposure were found. And these data support prior studies showing the safety of prenatal PrEP use and contribute to the few data exist on childhood outcomes following ARV exposure without the confounder of HIV exposure. Some exciting next steps for this extension cohort. We are currently quantifying PrEP exposure with TDF levels in maternal dried blood spots and also in hair. This current analysis is limited by using PrEP exposure or PrEP exposure by maternal report. And we will also continue to evaluate growth and then also bone mineral density via DEXA scanning through 60 months of age. And additionally, we'll continue to assess neurocognition and also using the Malawi Developmental Assessment Tool, which assesses neurocognition in several domains, including gross motor and also language. And this will help support our existing data currently shown about ages and stages in social emotional development. And lastly, I also wanted to draw attention to a few posters that are being presented here from a couple of my colleagues. So please take a look at those if you have not already. And in closing, I want to acknowledge and thank the PRIMA study staff, Community Advisory Board, County National Ministry of Health, and funders at the NIH for their support on this project. And most of all, I'd like to thank the women and children who participated in this study. And thank you for your time, and I'm happy to answer any questions.